Hello, dear students and friends. Today I am speaking on a topic, an obstetric emergency, which many a times we encounter in our obstetric practice. It is a condition which, if not managed properly and adequately in the golden hour, that is the first hour after delivery, may lead to tremendous morbidity and at times mortality of the mother. Yes, the condition is postpartum hemorrhage, and it is essential that we all must know all the details of the management protocols in order to save the mother. So, I would be speaking on evidence based management of postpartum hemorrhage. It is based on various international guidelines, especially RCOG guidelines. Now, blood loss exceeding 500 ml nearly complicates 18% of all deliveries. If there is severe hemorrhage more than 1000 ml, it is estimated to complicate 1 to 5% of all deliveries. And this condition is PPH. It is an important preventable cause of maternal morbidity and mortality. There is regional variation in the reported incidence of PPH, which is due to inaccuracy in clinically estimating the blood loss. However, standardized measurement of PPH is recommended to allow for comparison of data. In my presentation, I shall discuss the definitions, the risk factors, preventive aspect, that is active management of third stage of labor, quantification of blood loss, management which is protocol based and according to guidelines, and different modalities of treatment. Now, in this chart shows the definitions as per various organizations. According to WHO, blood loss more than 500 ml within 24 hours of delivery is PPH. It is severe if it is more than 1000 ml. According to ACOG, accumulative blood loss of 1000 ml or more, accompanied by signs and symptoms within 24 hours of birth, regardless of route of delivery, is PPH. According to RCOG, minor PPH is blood loss 500 to 1000 ml, and major PPH is more than 1000 ml, which is further divided into moderate 1000 to 2000 and more than 2000 severe. According to Society of Obstetrics and Gynecologists of Canada, any amount of bleeding that threatens the patient's hemodynamic instability is considered PPH. Now, let us look at the various physiological changes which occur in pregnancy. These hemostatic changes are very important. The coagulation factors, fibrinogen factor 7, factor 9, 11, 12, von Willebrand factor increase during pregnancy. The activated partial thromboplastin time is shortened by 4 seconds, but there is no change in prothrombin time and thromboplastin time. The total platelet count increases during pregnancy, but overall platelet count per volume decreases due to hemodilution. Basically, there is a hypercoagulable state to hasten clotting so that there is effective control of bleeding during the postpartum period. But what happens in PPH? There is excessive blood loss, which results in depletion of coagulation factors and platelets, decreased serum fibrinogen levels, platelet count decreases, APTT and PT get prolonged. Therefore, it is very important to replace them in order to ensure hemostasis along with other resuscitative procedures. The question arises, can we predict PPH? Well, in certain cases, there are risk factors, and these risk factors should be kept in mind so that we can identify which women may land up in PPH so that definitive arrangements can be made. These risk factors may be present antenatally or may arise intrapartum, and therefore our care plans must be modified when they are present. Clinicians should always be aware of risk factors. They should take these into account when they are counseling women about the place of delivery. Women with known risk factors should only be delivered in a hospital with a blood bank on site. This is a complicated slide, but it does tell us in toto all the causes of postpartum hemorrhage. The 4 T's: tone, tissue, trauma, and thrombin. And then the various factors which lead to these causes, like polyhydramnios, multiple gestations, prolonged rupture of membranes, fever, rapid labor, they may cause loss of tone, that is, overdistension of uterus due to polyhydramnios. There could be functional anatomic distortion of uterus due to rapid labor. Some uterine relaxants like terbutaline, halogenated anesthetics may be responsible for relaxation. Even bladder distension may prevent uterine contraction. Now, retained products of conception like retained pieces of cotyledons or even a succensurate lobe or even blood clots could lead to the tissue factor for PPH. Trauma to the genital tract by precipitate delivery, operative delivery, even malposition or previous uterine surgeries may cause trauma in the form of uterine rupture. There could be uterine inversion. These all are factors leading to postpartum hemorrhage. Thrombin is also another important cause. There could be pre-existing states like hemophilia, ITP, von Willebrand's disease. Even a history of previous PPH is a risk factor. Some conditions could be acquired during pregnancy, like gestational thrombocytopenia, preeclampsia with thrombocytopenia, as in HELLP syndrome. There could be DIC due to various factors like hypertensive disorders with adverse conditions causing coagulopathy. Fetal demise can cause coagulopathy, severe infection, even abruption, amniotic fluid embolism. Some women who are already receiving therapeutic anticoagulation for thromboembolic disease could also land up in postpartum hemorrhage. Now, this chart, I wish to highlight the other causes. Some conditions which are besides these four T's, like Asian ethnicity, anemia, induction of labor could be one of the causes leading to PPH, a BMI more than 35, prolonged labor, and age beyond 35. This is the risk approach. A prenatal assessment and planning must be done. We can identify these risk factors and classify women into three categories: low, medium, and high risk. And depending on that, all facilities should be kept in place so that these women are managed adequately. Like low risk, if she has less than four previous spontaneous vaginal deliveries, has had a previous singleton delivery, less than 2 prior cesarean deliveries, no previous PPH, and no bleeding disorder. This woman would require a type N screen on admission and oxytocin 10 units. But if she follows in medium risk, we have to discuss the risk of PPH with the patient and keep type N screen blood ready and continue oxytocin at least for 8 hours. If medium plus one more risk factor, then discuss cross-match 2 units of blood. But if she's very high risk, we can cross-match 4 or more units of blood and keep them ready. You keep oxytocin on flow for 24 hours and then observe. Now, at times, after the woman has delivered, the amount of blood loss is not appropriately estimated. And then that could lead to certain symptoms. So, if she has a normal blood pressure, but has palpitations, lightheadedness, mild increase in heart rate, there could be a blood loss of up to 500 to 1000 ml, that is 10 to 15%. But then, if there's a slightly low blood pressure, weakness, sweating, tachycardia, a blood loss of more than 1000 ml could be there. If her blood pressure falls to 70 to 80, she's restless, there's confusion, pallor, oliguria, and tachycardia up to 140 beats per minute. It means that nearly 2000 ml of blood has been lost. But sudden fall in blood pressure from up to 50 to 70 millimeters of mercury, lethargy, air hunger, anuria, and sudden collapse means nearly 2000 to 3000 ml of blood has been lost. So these factors, these symptoms should be kept in mind. Now the period after delivery, either vaginal delivery or a cesarean section, 1 hour after that is the fourth stage of labor. During this phase, adequate monitoring of the patient's vitals is essential. Systolic blood, and we should keep in mind these early warning criteria, which could help us in diagnosing PPH earlier, like a fall in systolic BP less than 90 or more than 160, a diastolic BP more than 100, heart rate less than 50 or more than 120, a respiratory rate falling less than 10 or more than 30, fall in oxygen saturation less than 95%, and oliguria less than 35 ml in 2 hours. These triggers can address every possible clinical scenario which could be faced by an obstetric clinician, and even the healthcare workers, the nurses who are looking after these patients should plot an early warning chart, Mayo's chart, which helps us in identifying these women earlier. So, PPH could occur in these at-risk pregnancies, but it can occur in a pregnancy which is not at risk or which is low risk. Therefore, it is unpredictable. You've never imagined that this woman could land up in PPH. So you would agree that PPH is an obstetrician's nightmare because most of the deliveries occur at midnight. Prevention is always better than cure. And for PPH, we can minimize the risk by active management of third stage of labor. Prophylactic uterotonic should be routinely offered for management of third stage of labor as they reduce the risk of postpartum hemorrhage. For women without any risk factors delivering vaginally, 10 units of oxytocin by intramuscular injection is the agent of choice for prophylaxis. And the whole sequence, 10 units to be given intramuscularly just after the delivery of the baby before cord clamping. Then delayed cord clamping, delivery of the placenta by controlled cord traction. Uterine massage has not been included in the recent guidelines. Uterine massage is to be done once you identify that the uterus is relaxed and there is excessive bleeding. Now, those who are delivering by cesarean section, 5 international units by intravenous injection, bolus intravenous injection should be used to encourage uterine contraction. Now, in absence of hypertension and in presence of an increased risk, ergometrin oxytocin combination can be used, and it has said that it reduces the risk of minor PPH. So for women at increased risk of hemorrhage, it is possible that combination of preventive measures might be superior to oxytocin alone. Clinicians should also consider the use of intravenous tranexamic acid, either 0.5 or 1 gram, in addition to oxytocin at cesarean section to reduce blood loss in women at increased risk of PPH. Now we come to the quantification. How can we quantify the amount of blood lost? Visual estimates are often inaccurate, and it becomes essential to quantify every woman's blood loss during and after delivery. This can be done by weighing blood soaked pads. So we have pre-weighed pads, and then after they are soaked, they are again weighed so as to calculate the amount of blood collected in them. Or we can use calibrated pouches to collect and measure blood. As you can see over here, a perineal pad soaked, half soaked, may collect 100 cc of blood. A perineal pad which is dripping, there is 300 cc. A full kidney basin, there is 500 cc blood. If blood is on the bedding, it could be 1000 cc blood loss. Similarly, blood from the bed has come onto the floor, nearly 2000 ml of blood loss has occurred. This shows a brass V drape, a calibrated drape which can be used at the time of vaginal delivery. It has markings. All blood which is lost at the time of delivery subsequently gets collected in this, and this could estimate the amount of blood loss. So what evidence says? Quantification of PPH is often subjective and visual. Data indicate that blood loss in obstetric patients is commonly underestimated. Objective measures of blood loss, including weighing of sponges, measurement of volume in pre-marked drapes, and assessment of hemoglobin, can assist in estimation of blood loss. When a collection drape is used, studies have shown reduction in maternal morbidity and mortality. So we cannot decrease the severity of PPH, but we can estimate the amount of blood which has been lost, and adequate management can be done. Now coming to the management. The basics of management: identification of severity of hemorrhage, communication with a multidisciplinary team, communication with the woman. We must know who should be informed when the woman presents with PPH, the various resuscitative measures, and the medical and surgical management. Now, this chart is a bit complicated, but it highlights the timelines. For initial management, only 30 minutes are there. By initial management, I mean management with uterotonic drugs. Now, if in the next 30 minutes after that, still she's bleeding, then some definitive measures have to be taken, and she is labeled as severe or persistent, having severe or persistent postpartum hemorrhage. The medical treatment: the various life-saving uterotonic drugs, oxytocin, methylargometrin, PGF2 alpha, and misoprostol. Coming to oxytocin, it has a rapid onset of action and short half-life. It is used in prevention as well as treatment of PPH. It has a direct relaxant effect on the vascular smooth muscle, and a rapid intravenous bolus injection, which is given usually at the time of cesarean section, has been associated with profound hypotension, particularly in presence of hypovolemia. It is structurally similar to vasopressin and has antidiuretic effects, so can lead to water intoxication and hyponatremia. So doses in excess of that recommended should never be given. RCOG recommends 10 units oxytocin intramuscular at vaginal birth and 5 units oxytocin bolus, slow intravenous at cesarean delivery. Now for treatment of atony, it is normally given by an IV route at the rate of 10 units per hour, 40 units in 500 ml crystalloids given at the rate of 125 ml per hour for at least 4 hours. Ergometrin is an alpha adrenoreceptor and dopamine receptor agonist which causes sustained uterine contractions and is effective in treating obstetric hemorrhage. But the disadvantage is that it causes vasoconstriction, resulting in transient hypertension, and is contraindicated in women with hypertension and severe cardiac disease. So it causes intense vasospasm, which may affect the cardiac vessels, and this is the reason why it is not routinely used. The other side effects include nausea, vomiting, concomitant administration of antiemetic becomes essential with its use. In prevention of PPH, it can be given as a combination with oxytocin in the form of symptometry. For treatment of PPH, it is normally given in a dose of 500 micrograms by slow intravenous or intramuscular injection. Now, prostaglandin carboprost PGF2 alpha is a synthetic prostaglandin and can be used when ergotamine is contraindicated or ineffective. Its adverse effects include bronchospasm, vasodilatation, hypertension, and increased risk of infection. It should be avoided in cardiac and pulmonary disease. It is given in a dose of 250 micrograms, repeated if required at 15-minute intervals to a maximum of 8 doses. But ideally, once we have given 3 doses and there's no response, we can try an intramyometrial dose, and the second line of management should then be adhered to. Newer uterotonics include carbetocin, which is an oxytocin agonist, and it has been studied for its effectiveness in preventing PPH. It has reduced the need of other uterotonics in after cesarean delivery according to a large Cochrane database trial. The need for uterine massage and overall risk of PPH when it is compared to oxytocin. So it is more effective than oxytocin. Now it can be given only at the time of cesarean section. So this use only has been approved till now. Misoprostol Pg E1 analog is a synthetic prostaglandin which is cheap, shelf stable, and can be used in under-resourced countries where other more expensive options may be scarce. Side effects include gastrointestinal disturbance, dizziness, headache, and most important, fever or hyperpyrexia. It can be administered sublingually, orally, or rectally, and the recommended dose as per RCOG is 800 micrograms sublingually. This is the flowchart or algorithm for massive obstetric hemorrhage according to RCOG Green Top guideline. So we come to the various portions one by one. A major obstetric hemorrhage, which is blood loss greater than 1000 ml, or if there is continuing major obstetric hemorrhage and there is clinical shock, always call for help. Shout out for help and mention the condition, like say that there is massive obstetric hemorrhage or PPH. Call a senior midwife, obstetrician, anesthetist, alert the hematologist, alert blood transfusion lab, and alert the consultant obstetrician on call. Second step is resuscitation. ABC, airway, breathing and circulation, an oxygen mask. Look for opening of the airway, give oxygen, which is to be given at an enhanced rate, 15 liters per minute. Fluids are given to maintain fluid balance, 2 liters isotonic crystalloid and 1.5 liters colloid till blood arrives. Blood transfusion, if group specific blood is not available, OH-RD negative blood can be started. Subsequently, group specific blood to be given. Various blood products are to be called for. Fresh frozen plasma, platelets, cryoprecipitate factor 7A can be used. Keep the patient warm. Now, these two should be done simultaneously, monitoring and investigation and medical treatment. So for monitoring and for giving IV infusions, a 14 gauge cannula is to be inserted. 2 such cannula are required. Withdraw blood for FBC, coagulation, urea electrolytes, LFTs, and send blood for cross-match. At least demand 4 units of packed RBC, FFP, and platelets, and cryoprecipitate. ECG monitoring, continuous pulse oximetry, a Foley's catheter should be placed. Hemoglobin bedside testing is essential. A massive transfusion protocol is alerted and various blood products are called for. Consider central or arterial lines if blood pressure is too low. Commence the record chart, weigh all swabs and estimate the blood loss. The medical treatment includes rub up the uterine fundus to help in its contraction, empty the bladder, initially give 5 units oxytocin slow IV. So you've already given the preventive management, that is 10 units intramuscularly. Now again give a 5 unit dose by IV bolus. Then give ergometrin, 0.5 mg slow IV or iron if indicated, and start an oxytocin infusion 40 units in 500 ml. After this, still if the uterus does not contract, carboprost can be given 0.25 milligrams IM every 15 minutes up to 8 times. An intramyometrial dose can be tried after the third dose. Misoprostol 800 micrograms sublingually, and consider the use of 1 gram of tranexamic acid IV. Still, the uterus has not contracted. Alert the theatre staff. Consider for examination under anesthesia, and consider for sending again repeated investigations to find if any clotting abnormality is still there or if it has been corrected. Now, once the medical treatment has been done, the uterotonics have been given, and still there is no response, we must move on to the non-surgical methods. And this should be done within 30 minutes. The intrauterine balloon tamponade, the brace sutures, and at this time consider for interventional radiology. Still, if there is no effect, consider surgery, stepwise uterine devascularization, or bilateral internal iliac ligation, hysterectomy. By experience, second experienced clinician needs to give consent, or uterine artery embolization. Once the condition of the patient is stabilized, the patient requires further care in a high dependency unit or an intensive care unit. This is an example of postpartum hemorrhage emergency cart. So all these things should be kept ready for high risk women who may have PPH, and this cart should always be ready in a labor delivery suite. Urinary catheter, lubricating gel, all sizes of gloves, especially elbow length gloves, vaginal retractors. These are the special type of retractors which would be helpful in traumatic PPH. Sterile speculum, sponge forceps, vaginal packs, balloon catheter kit, other curettes, needle holders, uterine forceps, lights, even a flow chart demonstrating the sequence of events, the various supplies for drawing blood, a biohazard bag, adult non-breather oxygen masks, tubing and filter for blood transfusion, pressure infuser bag, equipments for warming, irrigation, and intravenous fluids, and the medications, the uterotonics should be kept ready. So initially rubbing up of the fundus, and the uterus may compress the aorta and inferior vena cava. So in those cases, we can lift off the uterus so that there is adequate blood supply to the heart. This shows bimanual compression. After rubbing up of the fundus, if you still feel that the uterus is relaxed, one hand on the abdomen and one hand in the form of fist in the vagina, and we compress the anterior and posterior walls of the uterus. This is bimanual compression. This is aortic compression, 2 centimeters above and to the left of the umbilicus. Compress with the help of your fist. At the same time, palpate the femoral artery. Cessation of femoral pulsations indicate adequate compression. This can be used at the time of shifting the patient to the theatre, or in the meantime when all measures are being made. These are the 2 sites where aortic compression can be done. This is an important equipment, non-pneumatic anti-shock garment, especially at places where further facilities for management of these women are not possible. This garment can be wrapped around the woman. This prevents pooling of blood in the lower extremities, so keeps blood higher up and keeps the heart functioning while the woman is being shifted to a tertiary care center for further management. The balloon tamponade, in multiple retrospective and prospective studies, the use of this tamponade was associated with a decrease in need for invasive surgical interventions between 85 and 100%. And it is also a very useful resource in poor settings, resource poor settings. So it is effective up to 85%. These are the various types of balloon catheters designed for intrauterine use. The Bakri balloon, maximum volume 500 ml, and to be kept maximum for 24 hours. The BT Cat Utah Medical System, this also has a single silicone balloon, 500 ml capacity. Now a newer balloon, the EB Complete Tamponade System, this has two balloons, one intrauterine and one extrauterine, outside in the vagina, 300 ml vaginal balloon and 750 ml intrauterine balloon. This also can be kept for 24 hours. These are various other balloons which are not designed for use as an intrauterine balloon, but still can be used off-label. Rush urologic hydrostatic balloon, Sandstein blackboard tube, the condom catheter, and the glove catheter. So instead of using balloon, we can even pack the uterine cavity, the Schiffger's pack. A newer system, intrauterine vacuum tamponade, has come up. This consists of this intrauterine loop with vacuum pores. This could be of different shapes also. The basic concept is that this is placed inside the uterine cavity. A negative pressure is created, which helps in approximating the anterior and posterior walls of the uterus and therefore is effective in preventing excessive blood loss and helps in contracting the uterus. So all the blood which is collected inside gets sucked out and the anterior and posterior walls get approximated. There are various specialized hemostatic gauzes for intrauterine packing. Celox, which contains cytosine-derived polysaccharide granules, Cetox gauze, Pro, and Quickclot, kaolin impregnated gauze. Even simple intrauterine packing with a gauze pack has been tried. It is advantageous in many conditions, but the only disadvantage is infection. Coming up to the surgical procedures, the Belian sutures, suture material monocryl or vitryl or other rapid absorbed sutures, uterine cavities explored and checked, adequate tension should be there on the suture, shouldering to prevent uterine trauma, and drainage of blood clots is possible. The advantage of Belian suture is that it helps in compression of the upper as well as lower segment. So when stitches, this compresses the upper segment and this stitch compresses the lower segment, and it is more effective compared to other sutures. This is the typical way in which a Belian is to be applied, starting from the lower segment, below the uterine incision, above the uterine incision, from the anterior side going on onto the posterior side, coming back to the anterior side and closing the knot after closing the uterine incision. There's a sandwich technique. It is a possibility to combine compression sutures with intrauterine balloon. The suture must be inserted first. Clearly, inserting a suture after the balloon risks puncturing it. Moreover, once the suture has been inserted, the balloon can be used to apply counter pressure more effectively. Now, various stitches are also there and they have been tried and tested. This is the Pereira Stitch. It is a technique in which series of transverse and longitudinal sutures of delayed absorbable multifilament material are placed around the uterus in a series of bites into the submucosal myometrium. The basic aim remains the same, approximation of the anterior and posterior walls. This is a Chose stitch, also known as square stitch or mattress suture. These sutures are, if applied on the lower segment, in a case of placenta previa or adherent placenta, are very effective. This is the Haemorrhage stitch, usually resorted to when after a vaginal delivery, where sutures need to be applied. There's no cut open incision. So with the help of this suture, the upper segment can be adequately compressed. Now, if these brace sutures are ineffective, and in some cases we can do a uterine artery ligation just 2 centimeters below the uterine incision and another stitch 2 centimeters below it. but keeping care to avoid the ureter, which lies at this site as well. So this is the uterine stitch. Now, in some cases, stepwise devascularization, uterines of one side followed by uterines of the other side, then the utero-ovarian ligament and the ovarian artery of one side followed by ovarian artery of the other side. A temporary clamp, this shows a temporary clamp being placed in order to identify the effectiveness of stepwise devascularization or clamping the ovarian artery, which is a direct branch of the aorta. This shows stepwise devascularization. If this fails, internal iliac ligation, ligating the anterior branch of the anterior iliac artery. As far as evidence is concerned, efficacy of invasive second-line treatment to stop PPH in those who failed the first-line uterotonic and tamponade is uterine artery embolization is effective in 86%, compression sutures are effective in 75%, vessel ligation, that is internal iliac, uterine or ovarian, in 36%. Some patients received more than one second-line treatment and were more clinically complex, and still, in 1/4 of these patients, ultimately a hysterectomy was required. This shows endovascular balloon occlusion. So in some cases, like in cases of placenta previa, when you expect excessive bleeding and PPH, the catheter can be placed in situ, and at the time of dissection, this balloon, intra-aortic balloon, can be inflated so as to manage the condition. This picture depicts uterine artery embolization. Now, the last resort is hysterectomy. Recourse to hysterectomy is advised sooner than later, especially in cases of placenta accreta and uterine rupture, and this decision should not be left till the woman is in a bad shape, is in extremis. The decision for hysterectomy should be made by an experienced consultant obstetrician, and the opinion of a second consultant obstetrician should be sought. Subtotal hysterectomy is easier to perform, has a lower complication rate, and should be the operation of choice. But, however, in certain conditions, a total procedure may be required, like in those with cervical trauma, placenta accreta spectrum, or ongoing hemorrhage. Now, if bleeding continues after the uterus has been removed, a pelvic pressure pack can be kept, and it can be life-saving. With increasing incidence of cesarean section, the possibility of accreta should always be considered in the next pregnancy, and ultrasound magnetic resonance imaging are important. Anticipation and careful preparation in operation theatre could help in such conditions and is the key to successful management. So this pack can be kept if, in spite of hysterectomy, still the pelvic area is bleeding. The one end of the pack is kept through the vagina outside and can be removed after 24 hours. Other treatment options: intraoperative cell salvage. This is a safe and effective autologous transfusion technique whereby during surgery the blood loss is collected, filtered, washed, and returned to the donor. It has been commonly used in cardiac, orthopedic, and vascular surgeries and is found to significantly reduce the need for blood transfusion up to 38%, and absolute reduction up to 21%, and has been proposed for emergency use for PPH according to NICE and CMACE. Recombinant factor 7A is also a product which can be used in retracted cases of PPH, those which are not responding, but should only be used at a hematologist's discretion. Use may be considered as a treatment for life-threatening PPH, but should not be considered as a substitute, nor should it delay the performance of other life-saving procedures like embolization or surgery. Its routine use, however, has not been supported. Now, the use of blood components. Excessive blood has been lost, and our aim for component therapy is to keep hemoglobin more than 7, platelet count more than 75 into 10 to the power 9, prothrombin less than 5 times, 1.5 times mean control, activated prothrombin times less than 1.5 times mean control, and a fibrinogen level more than 1. This is a sample massive transfusion algorithm. By this, I wish to show the way in which it should be managed. There should be a team leader, a director, who identifies the various people who are going to function in the team, the runner, the reporter, and identify whether massive transfusion protocol has been activated or not. Once it has been activated, the runner goes to the blood bank, collects the MTP pack, the first pack which contains 4 units of packed RBC. The reporter notifies the blood bank, the lab, and records all investigations and all the procedures which have been performed. So once 4 units of packed RBC have been replaced, still she's bleeding, again she requires 4 units of FFP. So they are called for. Once 4 units of RBC and 4 units of FFP have been given and she's still bleeding and you've not received the reports of the investigations which you had sent, she may require platelets, single donor platelets 1 unit. Still, in spite of 6 blood transfusions, she's still bleeding. She does require a dose of cryoprecipitate. So depending on the investigation reports and the sequence, all these are called for. The runner brings them. The reporter notifies the lab and the director gives all these instructions. So instead of using whole blood, rational use of blood components, crystalloids, 2 liters of isotonic crystalloid and up to 1.5 liter of colloidal blood arrives. Blood, if immediate transfusion is indicated, give emergency group O Rh negative, K negative red cell units. Switch to group specific unit once feasible. FFP, its use should be guided by hemostatic testing and whether hemorrhage is continuing. PT and APTT, if they are prolonged and hemorrhage is ongoing, give FFP 12 to 15 ml per kg. If hemorrhage continues after 4 units of RBC and hemostatic tests are still unavailable, give further 4 units of FFP. Platelets, 1 pool of platelets if hemorrhage is ongoing and platelet count is less than 75 into 10 to the power 9 per liter. Cryoprecipitate, administer 2 pools of cryoprecipitate if hemorrhage is ongoing and fibrinogen is less than 2. This shows the various contents of various blood components. Whole blood contains RBC, platelets, and plasma. Packed RBC contains only RBC. FFP contains all soluble plasma proteins and clotting factors. Cryoprecipitate contains fibrinogen, factor 8, factor 13, von Willebrand factor, and platelets, group specific platelets are required. Now, in the end, documentation is the most important point or aspect to prevent medical legal complications. This is an example of obstetric hemorrhage chart. So this has everything mentioned on it. The time of call out, the person who did it, the date, and then the team members, name of the team members, and when they arrived. Then when these investigations, FBC coagulation, cross-match, coagulation screen, when the placenta was delivered, when the urinary catheter was inserted, all this, the amount of urine, the type of fluids, everything is mentioned in the chart sequence-wise. And then the medical management, when these uterotonic drugs were given and how much of them. When oxygen was started, when the cannula was inserted, and what further interventions must done. So this is a complete chart which should be strictly maintained, and there should be one dedicated person dedicated for this who should maintain this chart. Continuing care, continuing observation when patient is stable in a high dependency unit. Check hemoglobin and coagulation studies later on. Thromboprophylaxis, once bleeding is arrested and coagulopathy is reversed, consider thromboprophylaxis because this woman could have sudden pulmonary embolism because we've given a lot of blood products, even we've given plenty of platelets, so that could trigger an embolism. And here comes the importance of thromboprophylaxis only when condition of the woman has stabilized. Screening for coagulopathies if there are other indicators. Screening for Sheehan syndrome may be required. These women may not be able to breastfeed their babies, and in such conditions, screening for Sheehan's becomes important. Postpartum pituitary apoplexy may occur because of sudden vasoconstriction. Postnatal debrief is essential not only to the woman but to her partner. Give an opportunity to discuss the events and for them to ask questions and give further advice regarding future pregnancies. In addition to debrief the woman and partner, debriefing the team also is an important aspect so that they are then again ready for another such event. The basic take home message, these are the various pharmacological interventions, the uterotonic drugs, which are essential. These are the surgical interventions, which everyone must be well versed with. There are some interventional endovascular procedures in special settings which can be done. There must be a blood bank, and blood bank must have all these blood components. Some non-surgical interventions are tried before surgical ones. They should be kept ready. And important consultations, general surgery, trauma, anesthesia team, interventional radiology, gynec oncology, and urology may become essential in these women. So to conclude, for management of PPH, the 3 R's, recognition, response, and readiness. In recognition, quantification of maternal blood loss, PPH assessment, and maternal warning signs. So by this, we can recognize that PPH has occurred. Then immediate response in the form of transfusion therapy, PPH management. Then readiness by team debriefing, conduct a focused debrief as soon as the woman is stabilized. All postpartum hemorrhages that progress to stages 2 and 3. And simulation-based training of frequent PPH drills for these PPH teams is very essential. So thank you. If you have any questions, feel free to send messages and do subscribe to my channel to stay updated. There are some other good videos on obstetric emergencies, shoulder dystocia, uterine inversion, perimortem cesarean section, etc. Thank you.